Good afternoon, everybody. We're very good at starting on time, so we'll do that and hope that people trickle in and not miss anything. I'm Faye Gersh, the president of the Hemlock Society of San Diego, now in its 31st year in San Diego. How many of you are here for the first time? Oh, good. Well, welcome. So I'll explain a little bit about what our mission is. We believe that people should have a choice at the end of their lives consistent with their own values and beliefs in how they die. And we think they should be able to die a gentle, peaceful death with their loved ones around them. And in order to achieve this, often death has to be assisted. And we believe in physician-assisted dying and other forms of assisted dying. So we're here to present you everything we know as we know it on all aspects of end of life. And of course, besides talking about the dreaded D word, death, today we're talking about the dreaded other D word, dementia, which is a very serious problem. We have been addressing the issue off and on for the last 30 years, and we will continue to address it because now everybody in the world is concerned about it. There are now 5 million Americans who have been diagnosed with dementia in some form. Many of them are lingering in hospitals, institutions, and nursing homes with no quality of life, no personhood, totally dependent on care. Many of them would not want to live this way, and that's what we're addressing today. We have meetings every month, and so on alternate months, we don't meet here, we meet at the Mission Valley Library, and we have our Right to Die film festival, I don't know about that, film series. Festival happens all in one place, I think. Oh, it's very festive. Many of our movies are very entertaining. All of them are very serious, discussing the issue of death, often death that's wished and cannot occur. And actually, we always meet, we try to always meet on the third Sunday of the month. So on the third Sunday of February, in the Mission Valley Library at 1:30, we have a double feature this time. I don't know how many of you have seen the series on Lifeline, I think it's called, whatever channel that is, called Mary Kills People. Anybody seen that? You did. It's very good. It's an award-winning series. It's finished now. And so in February, whatever that date is, the 18th or whatever it is, 18th, we're showing the first episode of Mary Kills People and discussing it. It's a very serious movie, a series about a doctor who helps people die. And then we're showing a DVD by a Dutch doctor, Dr. Chabot, where several people are interviewed about their loved one's death using different methods. Refusal of food and hydration, the helium method, et cetera, et cetera. So, should be very interesting. It's a little longer program than we usually have, but we tried to show that second DVD before and we had technical difficulties, so we're trying again. So you're invited to all of these meetings. Generally they're free and open to the public, but the March meeting is not. The first one in a long time. It'll be for members primarily, and people who are non-members can attend for $25, and the presenter for that meeting just walked in the room. I don't want to put her on the spot, but she's Dr. Sally Hall, who will talk about the methods used by Final Exit Network. Sally. And so that's January, February, March, and we'll talk about that. If you want to find out what we're doing, you can get on our email list, or you can get our newsletter, which you can get if you become a member. And we encourage you to renew your membership today and join if you would. Our panel today will go like this. Hannah Wilder's mother-in-law is a person with advanced dementia. And Hannah's going to talk about her situation, how she didn't want to live like this, but she winds up living like this, and what can be done about this. And we're very interested in the response from the Alzheimer's Association. Amy Abrams will discuss that. She is the Education and Outreach Manager for the Alzheimer's Association of San Diego, an independent organization. Dr. Lisa Heikoff is on the advisory board of the Alzheimer's Association of San Diego, and also geriatrician at Kaiser. And she's spoken here several years ago and was very helpful then. So we'll see how hospice views this. And Dr. Bob Uslander is here, from the founder and head of Integrated MD Care, who has been very helpful with many of our members and other people in the community in providing them with a peaceful death. That is our objective here, is so that people can choose how to have a peaceful death when the time comes, what preparations to make, what choices they have. And this is a moving target. It's not once you join Hemlock you know everything, because things change, mostly for the better. Laws change, customs change, practices change. So join and keep up with the latest information. It's very important. At some point, you or your loved ones will want to know these things. So I'm going to sit down, and we're going to hear now from Hannah Wilder, who is the Communications Director for the Episcopal Diocese of San Diego and an Episcopal priest in training. Hannah?
I'm Hannah Wilder, and thank you, Faye. This is a picture of my mother-in-law, Ann Quinney. She goes by Amy, and this was a couple years before she retired and a couple of years before she was diagnosed with dementia. So, I'm married to my wonderful wife, Kathy Wilder, and it's her 42nd birthday today, so happy birthday, Kathy. And her mother, Ann, who goes by Amy, has Alzheimer's disease. Amy turns 75 next month. She has an advanced health directive, a trust, and this is a copy of her advanced health directive here. It's notarized. She has a trust. She has filled out the physician's orders for life-sustaining treatment, and everything's on file with her assisted living home. She lives in a home for people with memory loss, and it's on file with Kaiser, and she states in it that her life is only worth living if she can communicate with loved ones, be free from excessive pain, live without being hooked up to machines, and not be a burden to her family or others. She doesn't want blood transfusions, artificial feeding and hydration, or to be on life support for more than 3 days. In 2010, she gave my wife, Kathy Wilder, the power to make healthcare decisions, so Kathy may accept or refuse treatment, including accepting or discontinuing nutrition and fluid. So, being a teacher, she has been very clear. She has followed all the proper procedures. She's done everything legally, everything within her power to spell out what she wants. She had this document notarized, as I said, in 2010, and she gave it to Kathy at that time. And by that time, we were already seeing signs of her memory loss and working on getting it diagnosed. We finally did get it diagnosed with the help of the Shiley Marcos Alzheimer's Center. They used 2 volumetric MRI scans 1 year apart, and they could measure the shrinkage in her brain. And the doctor said that could only mean one thing, that it was Alzheimer's. So that was 2011. Fast forward to 2016, we moved Mom into a memory care facility, and about 6 weeks after she moved in, she got a skin infection on her back that spread. And at the hospital at Kaiser, they gave her strong antibiotics, and the infection responded, but it took a few days. And so after it had calmed down a little bit, the doctors saw that the skin in that area had died, and the doctors were saying she needed surgery for the necrotizing fasciitis. They said the infection was so deep that it had gone into her bones and into her blood, and that it would kill her. So they were ready to go that day, but Kathy wanted to discuss it with them. So they came down, 2 surgeons came down to Mom's room, and they took Kathy out to the hallway and discussed it with her. When she came back in, Kathy had decided to go ahead with the surgery. And what she told me happened in the hallway was this. The 2 doctors had said, this surgery is necessary. And Kathy said, well, have you seen her paperwork? Do you know what's on file? And have you seen her advanced health directive? And they said, yes, we've seen it, and we still recommend surgery. We're sure that she needs this surgery. And Kathy was still hesitant, and they said, it is unethical for you not to do this surgery. So in that moment, in the hospital, with a very sick mother whom she loved, and with 2 healthcare professionals telling her it was unethical not to have surgery, Kathy trusted their judgment. So her mom underwent the surgery. She had a frisbee-sized portion of her lower back skin and muscle removed. They cut all the way down to the bone and actually took some of the bone. And the surgery took a long time. I think it was over 2 hours. But the surgeon came out with a big smile on his face saying, she came through it like a champ. And we had prepared ourselves because he had said, people her age might not make it through and, be prepared. And we were prepared, and we thought it might be a blessing because she has Alzheimer's. Fast forward another 2 weeks, and living through MRSA, she got even more infected, but she's now at La Jolla Rehab on Torrey Pines Road, you may know it. And she's receiving care for this massive wound on her back, and having Alzheimer's, she's always pulling at the wound back, and she doesn't know about not getting up and being hooked up to things. So it's a nightmare because the staff at La Jolla Rehab, it's like they don't know how to take care of people with Alzheimer's. We had a nurse come in and say, now, Ms. Quinny, you just need to push this button when you need help. Remember that. Remember to push the button. And I'm going, really? Like, she's not going to remember that. So it's like they don't get it. But they do have a very good geriatric doctor there named Dr. Stephen LaFond. And he reviewed her file when he got in. And he said to Kathy, I'm surprised that you agreed to have this surgery because she clearly states that she wants comfort care only. And this was an aggressive surgery. It was major, and I don't really think it should have been done. So he asked for the names of the surgeons at Kaiser, which Kathy gave to him. And he said that he would be contacting them. And he said that if Kathy hadn't agreed to the surgery, she probably would have been dead by then. And that the infection would have taken her, but the hospital could have made her comfortable with pain medications. So of course that was an incredible moment of pain for Kathy and for me when she told me. So here we thought we had done the right thing by treating our mother for a serious infection, and yet really we had failed her, according to who she was, We had failed this woman. So she would have been free of Alzheimer's if we just let her body succumb to the infection back in the spring of 2016. But we didn't know. At that point, we didn't know what the right thing to do was. And when you're deciding about your mother's continuation on this earth or not, and the doctors are pressuring you, and in that moment, it's hard. And I don't know, but it seems like we're kind of young to be going through this. We don't have a lot of friends that have parents with Alzheimer's, and I'm 38, Kathy's 42. It just, we have no point of reference. So it's a tough call. It's not black and white when you're in that moment. But of course, knowing what we know now, and the way that Mom's life has gone downhill in the past couple of years, I can tell you that we are very clear, it's black and white, about what the right thing to do is. So now Kathy refuses all treatment, even simple antibiotics for anything. She's very firm and clear about this. And just last week, the home where she lives sent her to the ER because she had a seizure. And while we were there, they wanted to give her antibiotics for something again, and Kathy said no. And her mom is, in spite of all these health issues, she's resilient, she's strong, she has a healthy, strong body. She worked out 3 or 4 days a week her whole life. She always ate salad, she's in shape. She took really good care of herself, as you can see, which is a curse now because she's so physically fit she can endure aggressive surgeries. And it's not going to be easy for her to die. I was telling Faye, on TV, it's so easy. You just get a vial of something and you stick it in someone, and then they die. But it's really hard to kill someone, or to help someone die. So, I do have a picture of what she looks like now. I just want to show you. Thank you. I don't know if you can see this. And feel free to come up and look at this later, but this is her now. Yeah, she looks pretty good, but she's in a wheelchair. She can't put together a sentence. She doesn't know who her daughter is or her son. Yeah.
And she had a mother and a grandmother who had the same.
Thank you. I was about to say that. Yeah. So the thing is that her mother, so Amy's an only child, and her mother, Lolly, just died in March of last year at the age of 98. And Lolly had lived with Alzheimer's for 20 years. And Amy was the main caregiver. So she had seen and witnessed firsthand the loss of life, really. And then I was reading some of the old family history when I was writing the obituary for Lolly. And I came across a transcript of a conversation between Lolly and her sister, Kathy's great aunt. And it was fascinating because her great aunt said, oh yeah, Mom was a vegetable for 20 years. And back in those days, I guess people would call people vegetables if they had Alzheimer's. They didn't know that that wasn't nice. But so you can see it's a strong strain in their family. And so Amy knew that too, right? And she was prepared and she did everything she could. And yet she's still living in a home, not how she wants to live. So.
Okay, so we can take a few questions.
I could keep going if you want.
Oh, go ahead,
Can I say
Hannah.
more things?
No, yeah, don't look at me.
Just want to make sure I'm saying what you wanted me to say.
Well, just tell what the story is all I want you to do.
Okay, so I'll tell you a few more things. So being a teacher, Amy was prepared. She got great long-term care insurance, thank God, because that has made it possible for us to take care of her without one of us, stopping work and taking care of her, which is what we would have to have done. She's already paid for her cremation. She's already bought the little box. So she knew this was coming and she prepared for it. A couple other things about her. So she was born in 1943, and in 1964, I think she was about 21, she was in a car accident that was, she was sitting in the passenger side seat and her head hit the windshield and she had severe trauma to her brain, and the young man that was driving actually died. I mean, it was a severe car accident. And so the doctors, when she was diagnosed in 2011, said that they thought that played a role in her developing the Alzheimer's earlier than, say, her mother or her grandmother did. It still wasn't early onset, because she was in her late 60s, but it was pretty early. So to us, it felt early, of course. And then in the 70s, she married Kathy's dad and gave birth to her children. In the 80s, she got a master's degree and she taught special education in all grades from kindergarten through City College. And then in 2008, she retired from teaching. She was at La Jolla Elementary, and she was a great teacher. I mean, she would deck out her classrooms. They were just beautiful. She had a little tiny reading nook for kids, with a little carpet and beanbag chairs and little bookshelves, and so they had a little place where they could go and read. And once she was teaching a block on the ocean, and you walk into her classroom, there's beautiful cellophane strips hanging from the ceiling, so you feel like you're under the sea, and there's fish on the walls. I mean, very creative woman. She painted a mural on her church, and then, so she retired. She started docenting at the Natural History Museum, which if you've ever tried to do that program, it's rigorous. You have to be pretty smart and with it and capable, so she was doing all of that. Volunteered at her church, active in her community. She dreamed of going to England to see her family's home, but she never went. But, she went on outings with the Couples Club, which is a group of couples that met from her church. They'd been meeting for 30 years. But then just a couple years after she retired, she was showing real signs of memory loss, and we were noticing it, and friends and family were noticing it and talking to us about it, and it was very hard to get her diagnosed because she is so fit and attractive, and her hair is naturally this color. She doesn't dye it, and so. And she was very social. She's such a social butterfly, and so she could sit with a doctor for 10 or 15 minutes and answer all the questions and pass all their tests. They make you draw a clock with the hands. Well, she was an elementary school teacher. She could do that in her sleep. So it took a couple of years to really get her diagnosed, and it took me documenting what happened when, not knowing if she was sleeping or waking, if she was, dreaming, mixing up dreams with reality, and a lot of this stuff. So then, 2016, we moved her from her home into the memory care unit, and 6 weeks later, she had the incident with the infection. So now, it's 2018, she's in a wheelchair, she's incontinent, She can't hold a conversation. She doesn't recognize anyone. Her life is not a life. So thank you for your attention. I do ask for your prayers if you're a praying kind of person that she would exit this life that is not a life, and that Kathy and I would have the courage and resolve to help her do so. I ask for that. Thank you.
Thank you.
Thank you, Hannah. I hope that's not a scenario that is familiar to too many people in this room, but it could easily be. I'd like to hear from Amy Abrams about Alzheimer's of San Diego's response to this. I think we all admire what the Alzheimer's Association does as far as providing help for caregivers and respite care and the research that it backs. But my experience is that organizations that deal with very serious diseases never talk about dying, which seems to me so paradoxical and not serving their constituents. So I'm just wondering how you could help with this situation.
Sure. Well, first let me clarify. We're Alzheimer's San Diego. We're an independent and local organization, so not part of any national association. We just serve San Diego County, so let me be clear about that. And I'm also, I am staff there. I'm the education and outreach manager. I don't, however, feel that I'm in a position to speak on behalf of the organization and give a formal position or response. So let me just get all those disclosures out of the way. But I am, as surely all of you are, deeply moved and troubled by this story. I will say in my about 3 years working for Alzheimer's San Diego and about 15 years prior to that working as a geriatric social worker, a clinician, I've unfortunately encountered a lot of families facing this great chasm. There's this just huge gray area, a huge sort of missing spot when it comes to advanced directive planning by and for people living with cognitive impairment due to lots of things, including Alzheimer's disease, but certainly not limited to it. To the question of providers' reluctance to talk about the end of life, I would just like to say at Alzheimer's San Diego, we are very open to talking about the end of life. We offer regular classes that explore in great detail, open to the people that are diagnosed as well as family caregivers and professionals that go into great detail about the stages of the disease and what happens at the end of Alzheimer's disease so that people are prepared for that. We do legal and financial planning classes that are taught by estate planning attorneys. And yes, the topic of end-of-life planning does come up quite a lot in those classes, as you can imagine. And we actually have one specific community education class that is dedicated to the topic of, it's called Preparing for the Late Stage of Alzheimer's Disease, designed for the family caregiver who finds themselves in this situation so that they understand what happens when people are dying from Alzheimer's disease or other types of dementia, how to ensure that you've got access to palliative services, hospice care, and helping people find new ways to connect and communicate with somebody who is losing or has lost the ability to connect verbally with the people that they love. So we also offer a regular support and discussion group on grief and bereavement, as well as dozens of other support groups throughout the county for just sort of general caregiver interest and for the interest of people diagnosed with the disease. So I just want to say we don't shy away from that topic. We really encourage families to be knowledgeable about what to expect with this disease, and to support family caregivers throughout the journey. We're not just sort of giving people a bunch of statistics and sending them on their way. We do attempt to hold people's hand through that journey. I do wish we were in a position to change things about the way that advanced directives can be written, could be crafted such that down the road, a person who no longer has the capacity to confirm that what's in those documents is in fact what I want, we're not really in a position to push or support legislation like that.
Why not?
We are a very small organization. We actually we just simply don't have staff devoted to policy making, to legislation as a small local nonprofit. If there were such legislation out there, I assure you, we would be willing to educate people about it. We just don't have the internal capacity for that.
I had a few copies at the back on an advanced directive for Alzheimer's that was just published in the Journal of the American Medical Association. It's not law, but it certainly can state what a person's wishes are, from extreme care to everything, to I don't want any kind of treatment at all, and I don't want to eat and drink. So certainly advancing that kind of directive is not a great step, but it might help.
Yeah, which we do. In fact, we send templates for advanced directives, detailed advanced directives, and in fact, the Alzheimer's Association, the Washington State chapter, has a really wonderful detailed Alzheimer's disease advanced directive, advanced healthcare planning document that we will share with families when they ask for such a resource. We aren't legislators, so.
No, I don't think it requires legislation. Anyway, we can talk about that later, but we would be happy to speak to any Alzheimer's group that you have and tell them what the end-of-life options are. There are lots, like refusing treatment, which was happening in Hannah's mother-in-law's case, which wasn't honored. And doctors need to be educated. I mean, I'm not telling you what your job is, but it seems to me the Alzheimer's Association of San Diego and nationally is in the best position to educate families about the possibility of not keeping their loved one alive. I know death is not a pleasant alternative for people to talk about, but it's certainly, we talk about it here.
Yeah, we talk about it as well,
Yeah,
quite openly.
good. Glad to hear that. Lisa, I'd like to hear your point of view. You're on the Alzheimer's San Diego board and also a geriatrician and
I have so many things to say. I'll try to stay focused. This story is just triggers so many emotions and thoughts. Among the other hats that I've worn has been as co-chair of the Bioethics Committee at Kaiser Permanente Medical Center for many years, where we often take up discussion of cases where there is conflict between providers, between families and providers, between patients and providers around what is the right course of action. And I have to say that I'm very sad to hear that two surgeons pushed for this without stepping back and saying, let's have an ethics consultation and bring in the ethics consultant. I don't think it's for any one physician to use the words unethical. I think that is so loaded, and there are many different ethically defensible paths to take in any situation. And that's the goal of an ethics consultation, is to say, what are the choices that are being looked at here? Which of these has, support as an ethical choice? And, how are we going to help this patient, caregiver, family grouping to make the right decision for this patient? And had an ethics consultation occurred prior to surgery, perhaps there would have been I suspect there would have been a very different outcome. One of the challenges in doing surgery on patients with a no CPR order is also getting surgeons to honor the no CPR during the perioperative period. So you may have a no CPR, but you fall down and you break a hip. Well, it's very hard to heal and even just control pain from a broken hip if you don't pin it. And so some people choose to have it pinned mainly for pain control, not because they're trying to live longer or whatever. And yet, if something were to happen in the operating room, you would not want to be resuscitated. It would be like, okay, it happened, I'm done. And some surgeons really are sort of like, I don't want that to happen on my watch, and anesthesiologists as well. And so that sometimes, we have a whole policy that reflects that these orders are to stay in effect during surgery, but it often is helpful to have that consultation ahead of time and make sure it's very clear to everybody involved what the plan is before that person receives any anesthesia. So one thing to just remember, every hospital in town has, by requirement, a bioethics committee that can review situations. And it's not limited to people in the hospital. If you're part of a medical system, it can be an outpatient situation as well. You do have a bioethics committee available to you to review a particular decision that you're trying to make, especially if you feel like you're not being listened to by the medical providers. So please keep that in mind as an option. Ms. Demita, who's sitting in the back, is the co-chair of a county-wide bioethics committee, so there's a lot of sharing within that bioethics community about these kinds of issues. We have a fairly sophisticated bioethics community here in San Diego, in part thanks to Mitz's efforts. And so that's an option that it sounds like was not even offered to you.
Yeah, I didn't even
that
know.
would have been a help. One of the other things that comes up is this whole issue of refusal of nutrition and hydration, not the IV kind and not the tube kind. We all know that we have the right to refuse that for ourselves or if we're the surrogate on behalf of a loved one. The issue of voluntary not eating and drinking, so that's easy to do if you have your wits about you and you've made a choice and you're choosing to do that, and you may understand that the beginning of it could be uncomfortable, and that it gets easier as a little bit of time passes, and the biochemistry changes, etc. But for a demented individual for whom eating is a very basic satisfaction and instinctive thing, it is very difficult, I think, for people to withhold that from someone as a way of hastening death. And in fact, in institutions, La Jolla Convalescent, the memory care unit, they are not allowed to do that. So we also come up against regulatory issues. We're not allowed to withhold food and fluids. If somebody cannot take them and you assist them and they still cannot take them, that's okay. But that tray has to show up, that food has to show up by law. And so we do sometimes see ridiculous things where there's a heap of food on a tray next to a clearly dying person. These are some of the battles that need to be fought on a regulatory and legal basis that lie ahead of us. I think the elephant in the room is why can't you put in your advance directive that you would like aid in dying if you become profoundly demented, and what your parameters would be, and that is not legal. The society takes other approaches to that, which I won't go into, but from a legal standpoint and from what you can ask a licensed physician to do, that's not an option. So
It is in other countries.
it is in other countries, but it's not an option in the state of California. So that's not going to happen in the near future. So my next question, I'm glad to hear that Steve has been so helpful. I hired Steve. Go Steve. Dr. LaFont.
Oh, right.
I think geriatricians are very important providers, and there's not enough of them out there. But is your mother-in-law now eligible for hospice care? And rather than having her go back and forth to the emergency room and having to constantly over and over say, no, we don't want that, we don't want that, is she now felt to be in a 6-month prognosis, or is she such a sturdy person that now she's kind of pulled herself up out of that realm?
Yeah, I think it's the latter, unfortunately. She's really strong.
And that's one of the challenges, and again, a legal, Medicare, regulatory thing that physicians face. We can't put somebody on hospice because they have an advance directive that says, should something happen, I don't want these treatments. We have to say, I think they're in a 6-month time frame for them to be on hospice. That's where other approaches to palliative medicine come in. That's where Bob Wislander's practice has taken up some of the slack. But palliative programs that are kind of pre-hospice are few and far between. But that's where we need more and more of those. So I'll stop hogging the mic here.
So even though the nursing homes are required to provide a tray of food, they're not required to put the spoon in the mouth and do spoon feeding. They can put the spoon over here and say, are you hungry, Mrs. Jones? And Mrs. Jones says nothing, the spoon goes away.
Actually, they're required to attempt to feed the patient. They are actually required to attempt to feed the patient. Now, if the patient spits it out, they can't force it down.
Or doesn't open the mouth.
or doesn't open their mouth. You cannot force open the mouth of a patient. You
Once the
cannot
spoon enters the mouth.
shove food. But if you, and this is the challenge, everyone is so different. I've cared for so many patients with advanced dementia over the years, and for some of them, food is their one comfort, it's their one thing that they're very focused on, it's the only sort of positive spot in their day. I lost my brother-in-law a little over a year ago to early onset Alzheimer's disease. He was exactly my age, one day younger than me. He was a brilliant scientist. He worked at the Salk Institute, and then he was a professor at Brown University, and he developed early onset Alzheimer's in his late 50s and died 5 years later, very rapid decline. I saw Mike 6 weeks before he died, and he was still wolfing down his food. That was the bright spot in his day. And much as he, as a scientist, would have, and a very dignified individual, would have hated the situation he was in, and my sister knew that, and he had all the advance directives and all the paperwork, she couldn't possibly have withheld food from him to try to make this go faster. It was just not something she was going to be capable of doing, and it would have caused emotional suffering for him at that point in time. When he had his third episode of pneumonia, and it was hospital or no hospital, it was hospice care, he died in 8 days. So these things can be challenging, and you have to really kind of individualize. If somebody is clamping their mouth shut and does not want the food, then you are not required to push that food down their mouth or to put a tube in. And I think we've crossed that barrier, pretty clearly.
Thanks, Lisa. It's Dr. Bob Uslander, who, according to Lisa, has the solutions to this.
Go, Bob.
No solutions to that. So, like Lisa, as a representative of the medical community, I am appalled at the way things went down for your mother-in-law. And I think in addition to the ethics consult and committee getting involved, I would think that the other option that all hospitals, and most hospitals, certainly in San Diego, have access to is a palliative care team. And anybody who's in the hospital who's dealing with any kind of a complex illness, and they're looking for additional guidance from people who are really looking at the big picture, taking the 64,000-foot view of what's happening with a person's health and well-being. The palliative care, inpatient palliative care teams are usually available and very responsive, and they probably would have weighed in and communicated with the surgeon and been an advocate in allowing your wife to honor her mom's wishes. I looked through the Advanced Healthcare Directive, and it's a pretty standard one, the standard California Advanced Healthcare Directive, and it's pretty basic. What it does is it gives her agent, her daughter, the authority to make healthcare decisions on her behalf. So she could have chosen to go forward with the surgery, not have the surgery. She allowed her daughter in this document to make those decisions. And at that point, then it's a matter of the healthcare system supporting her and making the right decisions. So I think one of the things that I want to, there's a couple things that I want to try to impress upon everybody. Number one, you need advocates. You need to have advocates when you're in the hospital and you're in that situation, because you are no match for the team, the people that are there. They have other motivations. Some of them are pure. Some of them are just to get done with their day. You don't know, and yours or your loved one's well-being is at stake, and you need to find the advocates who are going to help you make those difficult decisions. I wish that there were objective advocates that are available for anybody who's in the hospital, and that's kind of something that I'm looking to try to help make happen. Find nurses, social workers who are willing to be private advocates for people in the hospital setting, because the advocates that are there, they all work for the hospital, right? And so even though they may have the person's well-being at heart, there's a lot of other influences that they're working under that will come into play. So number one, have advocates that can help you make those decisions. Seek out the ones that are there at the hospital. The palliative care people are going to be your best choice, or your best chance of having your needs honored or your wishes honored. the ethics folks as well. And the other thing that I want to really implore is to make sure that you're doing the appropriate advanced care planning, because you can make much clearer decisions and requests in advanced healthcare plan documents than what's traditionally done, incorporating things like the Washington refusal of food and water for dementia. And I think I have a document that I'm helping people put together, which really makes it very clear. It's what I would want, and of course they're coming to me with this request to help me craft the document that's going to allow me to have my wishes honored, and specifically to say at what stage you would not want to have food and water offered to you. And it's really important. And whether this document would ultimately be honored by a facility that your loved one is in is questionable. What would happen if it actually went to went to court? I can't say for sure, but I do know that if a person makes it very clear in the documentation that when I get to the point where I don't recognize my loved ones, I can't carry on a meaningful conversation, and I am not requesting food and water, I demand that it not be given to me, then that gives families the backing to take that course of action when they choose. And again, I can't say that if somebody comes in and says that's illegal, that it would actually hold up. I haven't heard of anybody who in that particular circumstance has been prosecuted. But I think that the other really important piece of that is the only way that anyone could do that and work with their own family in that way is to have them outside of a facility. You're not going to fight the facility. You can't be deceptive and hope that nobody's going to notice. Or I mean, you can go to the facility, and when they bring the meal, say, well, it's okay, we'll take care of feeding mom. You guys, we'll take care of it. But you'll still likely run into some challenges. So in a setting like that, when people have wanted to take that course of action and they have it all clearly documented, the best thing to do is to take the patient, to take that loved one home and honor them in the privacy of their home, your home, someplace where there aren't prying eyes and people having to determine if they're comfortable with it, from an institutional, corporate standpoint.
I was going to say, we have a friend at the V who's in the memory unit there, and finally the whole family has agreed to not offer her food and fluids. The objection is now not coming from the V, but from the caregiver, who is threatening to sue the facility for murder if they don't feed her.
So you never know where these objections are going to come from. Who's going to not be comfortable with it. So it's really critical. These are intimate, very personal scenarios, and they really need to be handled in that way. And as a physician who's in private practice, one of the things that I get to do is have conversations and guide people towards making the appropriate and right decisions. Well, first I try to make sure that people have the right documentation before the fact. That's really important. And then trying to look at all the options that are available and give the appropriate guidance. And then help them understand who needs to be part of that team. There are times when if the person hasn't indicated what they would want and given that directive, well, then it's a different scenario. And then I try to have people look at what you have to make decisions based on your comfort level with what you're seeking. Most of the time, I try to ask the loved ones to imagine that the loved one that we're talking about is telling them, is sitting there and looking at this situation, from the perspective of being a healthy, fully competent person, what would they tell you to do? What would they say? And most of the time that's pretty clear. Whether you can comfortably or legally do that or not is a different scenario, it's a different story. But it's certainly worth having conversations with people who are open to looking at all the different possibilities and providing that guidance, right?
We've really been talking about people who are already demented. We haven't talked about people who have early dementia who would like to take a step of ending their lives, which is possible. We have talked about that here. Final Exit Network will work with people, teach them how to end their lives if they're still competent at all. There's books, some of the things we're going to show in our film series talk about how to do that. So it's possible to end your life before you wind up in a state like your mother-in-law. Not a pretty scenario because you still have quality of life.
So I think that's an issue, and that's where sometimes the disability community, the dementia community, there's different sides to advocacy in this situation. And so I agree that the person with early dementia, early stage dementia, needs to really have an opportunity to speak to some of these issues. I can't personally, as a physician, support somebody suiciding at that point, but that's a sort of another issue. I just want to share a little story about something that happened with my brother-in-law that really impacted my view of early stage dementia and how important it is, number one, to disclose the diagnosis and be very candid and very open about it, and to use that time of life as an opportunity to really seek understanding about what this person wants for him or herself during this time going ahead. And one night, about 6 or 8 months after Mike had been diagnosed with dementia, Mike, who was a scientist and a self-proclaimed atheist, and raised the kids Jewish because that was my sister's wish, and he was fine with that, but never was going to convert because he didn't believe in God, and he just felt that wasn't authentic for him. About 6 or 8 months after he was diagnosed, he turned to her after dinner and he said, "I'm ready to convert to Judaism." And she said, "Mike, why now?" And he said, "Well," he was a practical guy. He said, "Well, I want to be buried in a Jewish cemetery so I can be next to you for eternity." And that was a recognition that he knew this was a fatal illness, that he understood, that he was going to die from this. So there was meaning to that beyond the practical. And then he said, I've been cut off from my academic community, my science community. I just feel the need to be part of a larger community. And so he was able to articulate this despite the fact that he'd had to give up his teaching, he'd give up his research. And so he did do that. He couldn't learn the stuff he needed to learn. My sister just sort of did it with him. And he had a conversion service, and it was extremely meaningful to him. I don't think he became a theist necessarily, but the process, the Jews and atheists, there's a few of us around, right? But it was a very important landmark in his life that he engaged in well after the diagnosis had been established. So it was such a lesson to me about the value of openness and candor during the early stages of diagnosis and living with dementia, so that important things can be accomplished and these kinds of decisions can be overtly discussed. So I just wanted to share that story because I think we often, just like we didn't talk with cancer patients about their prognosis years ago, there's such a stigma to talking about dementia and pretending it's not really happening, and that's such a huge disservice.
One possibility, of course, is people. Well, Still Alice was a movie that we showed in our film series.
Yes.
Everybody's seen that, and that was so pathetic because she had the medication somehow. I don't know how she got it, or whether it was the right medication, but she had it, and then totally could not remember what it was for or where it was or anything. But I was going to say that some people do refuse food and hydration as a way to end their life in early dementia. And one book by Phyllis Schachter talks about how her husband did that. and all of the materials you need and everything. I just ordered 5 of them from Amazon. They're back there. You can order that book from Amazon. It's, you know, sort of sad to do it that way, but he was in a very loving situation, and it got done before he completely lost his personhood with advanced dementia.
And can I add? Further to the question about early stage dementia, I just want to share a resource that is available. We offer a 5-week free education and support program for people who are newly diagnosed with mild cognitive impairment or early stage Alzheimer's or another type of dementia. It's called Take Charge. It's for the person with the diagnosis and a care partner, whoever they identify as their primary partner in this journey. It's 5 weeks with our staff as well as physicians that come in and facilitate conversations. We talk about the stages of the disease. We talk about advanced directive planning. These resources are out there for people who are facing that diagnosis and want to start that conversation. I want to also, though, illuminate an unpleasant truth about this disease, and that is that about 50% of people who have dementia don't have any insight into their own disease. There's a phenomenon you may have heard of called anosognosia, a person who does not have knowledge of their own disease. And this, about 50% of people with dementia fall into this category. So they are inherently sort of set back even further in terms of being able to have conversations with their loved ones, with the people who are going to be their advocates, the people who are going to eventually, potentially be in a position to make decisions for them. So I think we can't just assume that every person that receives a diagnosis is going to be in a position to sit down and have some thoughtful discussion and planning with their loved ones on this topic. And I cannot agree more with Dr. Uslander about the importance of really explicit advanced directive planning. This is what we tell our families. Be as detailed, just as down to the nitty-gritty as you possibly can. You absolutely, your advocate, your person who's named as your agent may very well find themselves in a spot where they can't actually enforce it. But at the very least, they're not going to be living with the guilt. Did I do the right thing by withholding? They can be very, very clear. Please do not assume that your loved ones, know, well, she was a member of the Hemlock Society for 30 years, so I'm pretty sure, I know what she would want, right? Be really, really clear with them about what you would and would not want. Have it down on paper and have conversations as many times as you feel you need to. Because even, I just spoke with someone last week who had a relative with late-stage Creutzfeldt-Jakob, a type of dementia, and she was getting similar grief from hospice workers about withholding hospice workers, right? This guilt can really come at you for a hallway conversation with a surgeon, a caregiver in a care facility, a hospice worker, your friends, your neighbors. It can come at you from all sides, and please help the person that may need to make this decision for you down the road be able to do that with as little guilt as possible.
About 90% of Americans have that disease. They don't believe they're going to die, and they don't think anything.
You're right.
Can I add a couple other points? The stories that we've seen are we could fill up 2 weeks of nonstop with the stories of the challenges that we've encountered. I have a good friend whose mother has had dementia. Actually, she just passed away a month or two ago, thankfully. But she had pretty advanced dementia for 7 years. She was a brilliant woman, a math professor, really ahead of her time. But for the past 7 years, didn't know who anyone in her family was and needed full-time care and support. She was actually smiling most of the time. She hadn't spoken in years, but she was smiling and pretty easygoing. Much easier person to get along with than she was for her 75 years before that. However, her husband was in this state of limbo, right? His wife was institutionalized, didn't know who he was. And at one point, shortly before I met them, and this is when I was more of a traditional palliative care physician, she had developed a urinary tract infection and ended up going to the hospital, and she was septic. So she had an infection in her bloodstream, and was running fevers, and it was a potentially fatal condition. But no one ever actually asked anybody in the family if they wanted it to be treated. They just treated it. And the family thought, this is what you do. Everyone just guided them towards treatment, which for everyone, though most of us would be appropriate. And when we met, it was about a month and a half later, and they told me about this incident, and I shared with them that, asked them, like, in the future, if that happened again, do you want it to be treated? And they said, you mean I have a choice?
Exactly.
And they were so angry. They felt so kind of violated that they had been forced down that path, and that it subjected her mom to another several years of institutionalization, another several $100,000, okay, to pay for her care, and care that she would never want. So that was so I think having the early palliative care conversations with a physician who can guide what takes place, what happens in the future, is really important, because if you don't know what's possible, if you don't know what the options are, you will be directed by well-meaning but not really engaged healthcare providers.
With all due respect, there are palliative care doctors and hospice doctors that will not tell you and will not point you toward dying. They'll point you toward living. So it's better to talk to a Hemlock Society person or to integrated MD care. Somebody who talk about dying like it's not a crime.
There's a couple other people. And the first person who I helped end their life voluntarily, through voluntarily stopping eating and drinking, was a gentleman who Ray knows as well, and he had dementia, and it was progressed to the point where he would not be the place that he was living wouldn't allow him to be alone. He did mention to somebody that he would rather not live with advanced dementia, so he was thinking about taking some action. So the place came up and promptly nailed his windows shut. They took away his ability to be on his own. And actually they had a psychologist come and speak with him, and when he told the psychologist what he was thinking about, they sent him to a psychiatric facility. They put him on a 5150 hold and sent him in an involuntary hold to a psychiatric facility.
That's a place where I live.
Well, that really. So ultimately, he was able to very clearly articulate what he wanted, what he was afraid of, and he was very clear on the path that he wanted to take. There were challenges along the way. It wasn't as smooth and gentle as it could have been, but he got what he wanted. His family is very grateful. And then there's a woman who I was recently introduced to, who's in her late 70s, and she was kind of in the same boat as he is. She's a little bit less advanced, but she still requires people to be with her to make sure that she's safe when she's going out, and help her with medications and such. But she had told her daughters that when she was diagnosed with Alzheimer's disease, she had told her daughters, when I get to the point where I don't recognize you, I just want you to shoot me, I want you to kill me.
Yep.
So they ended up reaching out to me, and she made it very clear in our first meetings together that she was going to determine when she felt like she was kind of slipping to the point where she didn't feel like life had enough quality, and so there was no rush, but we were continuing to care for her, and I'd check in every month, and at one point she said, my friend went on this happy pill, and she told me maybe I should try the happy pill, and I said, fine, let's get you on the happy pill. So we started her on a small dose of an antidepressant, and it's for in the last 6 months she hasn't once talked about this idea of wanting to end her life prematurely. So she still has dementia. That hasn't changed, but her frame of mind has changed. And so you have to really be caught. You've got to meet people where they're at and understand that there's a lot of other factors at play. It's never cut and dry. So, but it does require the conversations and openness to talking about what the path would look like, what the future might look like, and look at putting in place different solutions or different approaches based on where the path is leading.
Okay, now we hear from you. Questions, Bert?
Do you want to announce it?
Oh yeah, Ken Watson is recording all this, so if you don't want to be on YouTube or on our website, don't ask a question or have your neighbor ask a question or cover your face or do something. Disguise your voice, I don't know. CIA is not watching.
We need to use those two microphones for questions.
No speeches, if you would, please.
Questions?
We've got two roving mics.
Hi, my name is Diane, and I'm a retired hospice nurse, and I was wondering, Amy, does your mother-in-law still have her wound?
Oh, wait a minute.
Amy's my mother-in-law, my Hannah, but she does, it's healed. So,
Oh, it has healed.
yeah, this took place in 2016 and she had a wound vac and,
Yeah.
yeah. Why do you ask?
Well, because I thought if she still had the wound, that they could stop treatment, it would get infected, she would get sepsis, and she would pass.
Thank you. It seems like she has a major health crisis once a year. In August, she fell and broke her hip. And she was holding a bowl and she was walking, and as she fell backwards and just didn't let go of the bowl, And so she broke her hip. And I called Faye and I was like, what can I do? And again, we were in that situation of, do we treat or not treat? But we thought, well, we want her to be ambulatory, so we did have the surgery. She's still remembering how to walk, so. But yeah, I mean, if anything ever comes up again, now we know.
Yeah. I'm sorry that you're all going through that.
Thank you, I appreciate that.
Yeah, I was wondering, you were talking about Washington, and you didn't go into detail in Washington. But is that what is the addendum for permanent cognitive dysfunction that we can add to our advanced care directive? Is that what you're talking about? And where is the status of that now?
So there's the Washington, what organization was it? What was it?
Well, End of Life Washington, but no, actually, there's several organizations working on how to develop an advanced care directive for dementia. The one we have came from JAMA, but End of Life Washington has developed one. I'm not sure which one you're talking about specifically. Well, Bill, we have something in our planning packet on advanced directive for dementia. This is Bill Simmons, our lawyer, who helped us and Mitt's work on our planning packet.
Yes. In the planning packet, there is an addendum for advanced care planning for demented people. It's based on suggestions from a Harvard professor, I think it was. Mitz is the one that actually rewrote it. Mitz can speak to it. We're seeing more and more of these kinds of supplements to your advanced directive. And the important thing is to look at the symbol and write it the way you want it. You don't have to use a form. It's up to you as to what you want to say in your advanced directive. The important point, which I think everybody up there is making, is that everybody should pay attention to this problem. If they're concerned, have a special page in your advanced directive on dementia and what you want to happen or not happen to you. Make it very clear. And have those conversations with your family, and you're done. They're more important sometimes than the paperwork itself.
This is the planning packet that Bill and Mitz wrote, a doctor and a lawyer, and it's their suggested donations for them back there. And they have a lot of forums and ideas, and they're helpful to have.
That's where I took it from, and I was just curious.
Where that came from. Yeah.
If it's been contested.
Well, I think what we need is some kind of adjudication on a lot of these requests that people make,
And then the institution says, no, we have to provide food. To what extent do they have to provide food? How far away does the spoon have to be? If the tray can sit there without the patient eating it, when does it get removed? All those things really need to be decided by the courts, which who knows what the court will say, but right now it's very iffy.
I'd just like to ask the Alzheimer's representative, if you have a sample of such a form that you hand out to people who ask for it at your Alzheimer's meetings, or at least if you tell them that there is such a form when you encourage people to work on their advanced directives.
I learned just about 30 seconds ago that the Hemlock Society offers such a packet. So I did not know that that resource existed, so I have to think that most of my colleagues at Alzheimer's San Diego don't know about it either. But yes, we do talk with families who are doing advanced directive planning about the addendums, about the additional details that they can get integrated into their documents. We don't have a specific document for any kind of advanced directive planning that we give to families. We direct them to resources to find those things.
How legally binding is the healthcare directive if created after a person already has symptoms? And it seemed to be easily challenged.
As long as they have decisional capacity at the time that they created the document,
but if they're having symptoms, then what's their division? What's the capacity level?
Yeah.
Yeah, so we look at decisional capacity really on a decision by decision basis. So a person can have decisional capacity to determine who they want to be their healthcare agent, to say some basic things about resuscitation and life support and medical care and goals of treatment, even though they might not have capacity to engage in a complex financial decision or a complex real estate transaction. So decisional capacity is decision specific, and that is recognized. The challenge is always when there is early dementia and no one has formally assessed the person's decisional capacity, a document gets created and then somebody comes in from the outside and says, hey, wait a minute, he already had dementia on his medical list. When you completed that, that's an invalid document. And so if you are going to complete a document after, or help somebody else complete a document after a diagnosis has been established, you really want to have the person's decisional capacity assessed by somebody with experience, a geriatrician, a psychiatrist, a neurologist who has experience in determining decisional capacity. So it's a long answer, but it's highly dependent on making sure that that timing takes place. I've been, I can't tell you, involved in how many family squabbles over whether or not, and this happens with wills as well, as you know. So.
Do it now, in other words.
Yes. My question is kind of taking the other side, and I'm glad we have an attorney here. Having worked in an institutional setting for a long time too as a medical social worker and dealing with these issues, I know darn good and well that the institutions themselves are very much afraid of litigation. And some physicians are afraid of potential litigation. And my question is, what can an institution, whether it's Kaiser, whether it's a SNF, hospice probably would not be as involved, do to protect themselves and make sure that they are protected from possible litigation from, as one of our doctors put it, someone who might come out from the woodwork.
It's got to be us this time. Not the Ann from Arkansas that is so sad that her cousin that she hasn't seen for 20 years is dying. No.
The answer.
Was there an answer?
Well, I'm happy to speak to that. So yes, there's a lot of people are very risk averse and litigation averse, and that's understandable for any of us who've been through any lawsuits. It's not a pleasant thing to go through. And you have to remember, this is a very select group of individuals here. We live in a larger culture where people actually fear the opposite from the healthcare system, that there are death panels and that people make, completely financial judgments about which life is valuable and which isn't, and that people are going to be, pulling back on healthcare from a financial standpoint. There are religious groups that are very concerned about things from a completely different perspective. So we have a complex culture that we practice in. That said, it's documentation, documentation, documentation. You have to have the conversations and you have to document the conversations. And this is where adding in both ethics consultations and palliative consultations really helps. It's where having individual programs to counsel people on creating advanced directives. We have such a program at Kaiser, separate from your medical care, where you meet with an advisor who talks with you and helps you to come to some conclusions and put things in writing. It's all about the documentation, which won't stop you from being sued, but will help you to, stand your ground about the decisions that you've made.
Could I just add one more? I think it's a really important question that you bring up, and I just want to say there are 2 organizations here in California you might contact in that regard: the California Advocates for Nursing Home Reform, CANR, or the California Advocates for RCFE Reform. These are 2 organizations that do lobbying work, and I think getting those organizations to address those regulations that keep them from being able to honor those wishes, I think that's a pretty critical hole that needs to be filled.
My question can be answered either by a lawyer or from those of you with experience. It has to do with decisional capacity to make these decisions about when to commence VSED. Is an MCI diagnosis, does that mean that you no longer have that kind of capacity?
No. Absolutely not.
No.
Mild cognitive impairment.
Right, no, mild cognitive impairment is not dementia. It's a person who has a diagnosis of MCI absolutely would, unless there was some other reason, they would absolutely still have decisional capacity. Anything?
It's a case by case.
I have a question.
Yeah, let me just say, obviously everything is case by case, so depends what the other medical conditions are, psychiatric conditions, etc. But in general, a diagnosis of MCI does not preclude decisional capacity. I'm sorry, sir, go ahead.
Very quick question regarding additional decisions to your medical directive. Does that have to be notarized, or can you just add whatever you think left out?
Witness.
A witness.
But Bill,
In California, you have a choice. You can have it notarized, or you can have 2 witnesses. You don't need both, but if one witness won't do, and under certain circumstances, some witnesses can't be witnesses. You can't have 2 family members, for example. One of the witnesses has to be outside the family. And there are some other requirements about the witnesses, especially if you're institutionalized. The easiest thing I recommend to people is get it notarized, then you don't have to worry about whether your witnesses are qualified or not.
I was wondering what advances there are in Alzheimer or mental disability in terms of medication. Is there anything going on in prevention?
Oh, well, that's another whole.
That's another story.
I mean, that's another whole talk. There's lots going on. Unfortunately, there's nothing immediate in the pipeline right now that we can say in the next couple of years there's going to be a drug out there that will either prevent Alzheimer's disease or prevent the progression, the disease progression once it's established. There's some promising things happening in a variety of arenas. I think for those of you familiar with the whole amyloid theory about dementia, I think some researchers are moving away from the focus on amyloid and looking at other proteins and other immunologic things, inflammation in the brain, the role of glial cells, which are the sort of neuroprotective cells. So there's a lot going on, but in the meantime, we're really still back to the basics of everything that's good for your blood vessels everywhere else in your body is also good for the blood vessels in your brain. And so exercise, healthy diet, and mental stimulation are really the things that we tell everybody to do no matter what. So, stay tuned. There've been a lot of disappointments along the way. There have been a few little breakthroughs. There's a drug that's related to turmeric, and that's been a whole turmeric. Are you drinking yellow milk in the morning? That's a whole thing. Turmeric and coconut milk or whatever. So there's a chemical related to turmeric that's being investigated that looks promising in mice, but going from promising in mice to being available for human research and then human approval is a long distance away. So we've got a ways to go on that one.
I'm going to just interrupt to say that we put surveys down on everybody's seat. So before you sit on them and then walk off, if you would please fill them out so we can get some idea of who comes to our meetings and what we can do to improve them or what's good or what's bad. Anyway, would you please, and leave them at the door?
I just want to make a comment about the latest investigation for Alzheimer's drug. There are 2 of them in the final stages of stage 3 clinical studies, and they're both monoclonal antibodies. And if you see a drug that has MAB as the last 3 letters in the chemical diagnosis or chemical name, that's monoclonal antibodies. And they're very promising. It's going to be at least 5 years before they get through, because after they go through the clinical stages, then you have to go through actual testing and everything else. So it'll be a while, but they're at the stage now with more promise for Alzheimer's than they have ever in history. And the goal is to see if they can slow it down. The next step can be stop it. The next step can be reverse it. And this is just to slow it down.
Any trials? Any trials?
Oh yeah, there are trials that do that. The phase 3 clinical trials, his trials, yes.
We have to get on with this because, I'm going to take the floor again. When the AIDS epidemic was happening and people were having horrible deaths, a lot of attention was paid to assisted dying. And a lot of people had better deaths because doctors would help them die. Then the treatment was discovered and these people did not die, and that was wonderful. Meanwhile, we have a very horrible disease here, which now causes progressive dementia and loss of personhood, and some people would rather die, and some people would rather wait for the treatment, and some people would rather get in a clinical trial. You certainly have your choice, but to wait while you're in an institution for years and years may not be the answer.
If I could just wrap the very large topic of the state of research and clinical trials and drug development, we have a lot of information available through Alzheimer's San Diego. So go to our website. We've got classes where we do research updates. We have social workers who can talk with you about clinical trials that are running here in San Diego County. Lots of and a lot of classes about brain health. And while we don't have a means of prevention, we do know how to lower risk. So there's a lot of education and information out there. It's all free and available to any one of you. So
Could you name your website again?
sure. It's so we are Alzheimer's San Diego, and the website is alzsd.org. So abbreviated, ALZSD.
Other questions?
No. That's it.
Hand.
This question is for Hannah. I just wondered if anyone in your family ever went back to that surgeon who put the pressure on Kathy to say that this was unethical, and if you ever considered writing a letter to the ethics committee at the hospital, let them know how it all turned out and how you felt by the pressure of that doctor, how your sister-in-law felt.
Thank you. Yeah, we have not done that. I think we were both devastated after we talked to Dr. LaFond and felt pretty angry. So we didn't feel we could connect with those surgeons in a helpful way. But now, a year or so has passed, and we probably should do that, and I think that I will. I will do that, yeah, because that's why I wanted to speak here today, so that other people could learn from our story. And you're right, I think those doctors should also learn.
I wanted to add, there's one more question. I wanted to add something that I thought about saying earlier, and this applies to your mother-in-law, and it may apply to other folks out there. The question of hospice care, and when it's appropriate, when she would qualify, that's critical. And of course, we don't want her ever to have to go to the hospital unless it's something that can't be managed and she can't be comforted. But it sounds like the goal is to keep her where she is, to reduce her stress, reduce any physical or emotional challenges. So one thing that can be done for people who are sort of borderline or may qualify for hospice at some point if they have a change in their condition, is to connect with a hospice agency and start the process. You can ask them to come out and do an informational visit and actually get documents and paperwork even signed in advance, and have this understanding that if things change for my mom, whether it's the middle of the night on the weekend or 9 a.m. on a Tuesday, if she has a change in condition, we would like to move into that mode, and we would call you, and because everything has sort of been pre-arranged, they would be able to send a nurse out, and do a hospice admission, and avoid having to transport that person to the hospital and go through the typical process. It may not always be available, but it's certainly worth looking into to avoid having to go through that really unpleasant experience.
Thank you.
Yeah, it's something to think about.
And there's a choice on the most recent POLST form that says hospitalize only if comfort measures cannot be provided in the current setting. So you really want to look at that POLST form and make sure you've got, it says request transfer to hospital only if comfort needs cannot be met in the current location. And then there's a place to add other things. And you might say hospice referral as soon as her condition changes.
Hold that up so people can see it.
Oh, it's right here.
So you're probably most familiar. Are most of you familiar with the pink POLST form?
We have them back there.
Okay.
So
Pat's holding one up.
the POLST form only becomes applicable if the person is unable to speak for themselves at that moment, and it gives their directions. So I have people who aren't even my patients, but I've met with them and I've gone over the advanced care planning, and we've helped them create documents. And on their POLST form, in a certain section it says, if I am unable to speak for myself or in this condition, call Dr. Bob Uslander and engage his services. And that's what people may do, because we can then come in and help protect them from the things that you talked about. And I don't mean to be plugging myself, that's not my purpose here, but I see situations like this all the time. And it can happen at Kaiser, and it can happen at UCSD, and it can happen at Scripps. The best institutions, the most well-meaning people, they're busy. Everyone is busy, and they may not be looking out for truly to honor the wishes of your loved ones. So sometimes you need to have some, like I said earlier, advocates and people to protect your loved ones from being, pushed onto that conveyor belt.
The lawsuits that doctors are worried about are the ones from Antilles, says you let my mother-in-law die. And I think it's time for us, churches, whatever other groups, certainly the Hemlock Society, and we're looking always for volunteer lawyers here, for us to bring the lawsuits. I think what happened to your mother-in-law is appalling. I mean, you've written me much more graphically how you felt about being shamed by these doctors. That's a disgrace. So stop worrying about Antilles suing you and start worrying about us suing you, because we're perfectly capable of doing that. Anyway, thank you for coming, and our speakers, thank you very much, all of you.